Good evening, doctor. So we have covered a lot of things in genetics. So we are now on multifactorial inheritance. So what we've covered is we've covered autosomal dominant disorders, we've covered autosomal recessive inheritance, we've covered the X-linked ones, and we've covered some topics on trinucleotide repeat disorders. We've covered chromosomal abnormalities, karyotypes, Turner syndromes, and mitochondrial inheritance, genetic imprinting disorders. And now we shall be doing multifactorial inheritance. So genetics is a very volatile topic and everybody feels that. I'm sure the students who were there in the last class, they remember whatever we discussed last time. Is that it? Yes? You remember most of the topics?
Yes, sir.
Great. So this time around, we will be finishing genetics, and these are very interesting topics, and they come repeatedly in the exam. So let's do multifactorial inheritance. Basically, multifactorial inheritance is caused by the interaction of genetic and environmental factors. And a very, very common example is skin color. So skin color is basically multifactorial. Not only it is genetically predetermined, it has polygenetic inheritance. So polygenic inheritance, not just one gene is responsible for skin color. Moreover, the exposure to environment can also change the skin color. Hence, the example of multifactorial inheritance. It is caused by interaction of genetic and environmental factors. Other pathological examples would be neural tube defects, diabetes mellitus. If somebody has a gene which can cause diabetes mellitus type 2, they can actually keep their weight lean, they can avoid carbohydrate intake, keep exercising, and these people can actually have a well-controlled diabetes even if they get it. Then hypertension is also multifactorial inheritance. Now, why do you need to remember this? Because these two topics have been asked in the exams time and again in true and false statements. That diabetes mellitus has a multifactorial inheritance. That is correct. So is correct for hypertension. Let us take an example of a case scenario that a couple has a child with spina bifida. Now, the mother is currently pregnant and is asking you about preventive measures. Can I prevent my second child from getting spina bifida? What is the chances of my second child also having spina bifida? So what will you recommend? Increasing protein intake, prenatal vitamins with folic acid, early ultrasound to detect abnormalities, and avoidance of tetrogens. Any idea?
Prenatal vitamins.
So we would like to give this patient a good dose of folic acid. So folic acid replacement we will do. So neural tube defects is a multifactorial disorder and it can be prevented with folic acid supplementation before and during early pregnancy. A 50-year-old man with a strong family history of diabetes mellitus develops polyuria and fatigue. So he's 50 years and he has a strong family. Strong family history means either the parents have diabetes or the siblings have diabetes. What is the genetic basis of this condition? Now, this question has again, time and again appeared in the exam. So, autosomal dominant inheritance, polygenic inheritance, X-linked inheritance, or autosomal recessive inheritance. So, what is the answer to this question? The answer is polygenic inheritance. So, type 2 diabetes mellitus is a multifactorial disorder caused by multiple genes and also combined with environmental factors like obesity and lifestyle. So, this was about multifactorial genetics. Now coming to structural chromosomal abnormalities. Now chromosomes, they basically, each chromosome is taken from one parent So each limb of the chromosome. So this is how the chromosomes are formed. So let us say some part gets deleted or some part gets duplicated or some part gets translocated or some part gets inverted. For example, let us say ACC becomes CCA. So this has actually inverted its position completely. So this is an inversion. For example, Cry-Du-Chat syndrome, Di-George syndrome, and Robertsonian translocation. We read about Robertsonian translocation in Down's syndrome. Okay. So let us understand from questions how questions can come from structural chromosomal abnormalities. A newborn with a weak, high-pitched cry is noted to have a small head microcephaly, hypertelorism, and a ventricular septal defect. Genetic testing reveals a 5p deletion. What is the diagnosis? So 5p deletion. Now deletion is a structural chromosomal abnormality. You need to remember that. They can ask in this fashion also. Although the answer is known to everyone, it is Cry-Du-Chat syndrome. Yes, it's a Cry-Du-Chat syndrome. And it is caused by the deletion of short arm of chromosome number 5. And the children, they cry like a cat and they have intellectual disability because their frontal lobes are small sized and facial abnormalities. So they look like, this is how they look like. They look like this. So microcephaly with hypertelorism and facial abnormalities. This is how they usually look like. It is Cry-Du-Chat syndrome, 5p deletion. 5 is chromosome number 5. P is the short arm of chromosome. Long arm is known as Q, and it is deletion. A 3-month-old boy with hypocalcemia, tetany, and a congenital heart defect. Genetic testing shows microdeletion in chromosome 22, long arm, 11 segment, second base. What is the most likely diagnosis? Cry-Du-Chat, Turner, Di-George, or Beckwith-Widman? So this is classical Di-George syndrome. So in Di-George syndrome, there is thymic hypoplasia, hypocalcemia, cardiac defects, and T cell deficiency. This is a total cramming. I know it is a ratta. But then you need to remember that Di-George syndrome is not a mitochondrial inheritance. Di-George syndrome is not a multifactorial inheritance. Di-George syndrome is not an autosomal recessive or autosomal dominant or an X-linked disorder. Di-George syndrome is basically a problem with the long arm of chromosome number 22. And in that long arm, 11 segment, second base is deleted. So this is micro deletion. As far as Cry-Du-Chat is considered, it is basically a large deletion on the short arm of chromosome number 5. So that is Cry-Du-Chat. Di-George is 22q11.2 deletion. Is that clear? This is, although this is cramming, but you need to remember this. Okay? Very important. Robertsonian translocations, दो ही तो हैं usually which will be asked in the exam. Cry-Du-Chat and Di-George syndrome. Sir. Okay.
Sir.
Yes?
Also, one time Di-George syndrome.
Say again?
Di-George syndrome.
Yeah, you want to know about it?
Yeah, yes.
Okay. So basically, Di-George syndrome we study in pediatrics usually, but for us in genetics, it is important. What I should say, it is an important disorder because it is associated with a particular kind of genomic deletion in which there's a deletion of second base on the 11th segment of the long arm of chromosome 2. So Di-George syndrome, in effective, it's basically a pediatrics domain. It is associated with T cell deficiency. So it is basically an immunodeficiency disorder. So immunodeficiency disorder of T cells, and also there is a deficiency of development of third and fourth pharyngeal pouches. So what is the tissue which is derived from third and fourth pharyngeal pouches? Mediastinum, thymus. So there are problems with the thymus development. Then there are conotruncal abnormalities. Why? Because again, mediastinum, conotruncal. Conotruncal means the aorta and the pulmonary artery. Now these are problematic. All right. So truncus arteriosus, tetralogy of Fallot, interrupted aortic arch, ventricular septal defect, they all can occur in DiGeorge syndrome. Then thymic hypoplasia will lead to what kind of deficiency? Which cells will be deficient? In thymus hypoplasia, thymus is known for T cells. So there will be T cell deficiency in this condition. And if somebody is T cell deficient, they will be prone to which infections? Viral infections. They will be prone to which infections? Fungal infections. So, and also to tuberculosis, atypical infections. So these are the problems of T cell deficiency. Okay. Also develops from third and fourth pharyngeal pouch is a gland known as parathyroid gland. So parathyroid gland will be deficient. So if parathyroid gland is not formed, then what will we see? The patient will have hypocalcemia. And what will hypocalcemia do? Recurrent fractures. So pathological fractures, or what can happen? Tetany can happen. What can happen? Tetany and seizures can happen because of hypocalcemia. And mental retardation can happen because of hypocalcemia. So because of the deficiency of third and fourth pharyngeal pouch formation, there are deficiencies, or what I can say is non-formation of thymus, of conotrungus in the heart, of parathyroid gland, and of course multiple craniofacial abnormalities. Like I drew a face for you, dysmorphic feature. The ears will be large, the mouth will be small, there will be hypertelorism, and they can have cleft lip or cleft palate. Other problems are intellectual, of course. They will always have a mental issues with them. So how do you diagnose these patients? How do you diagnose? So diagnosis is based on number one, clinical features. So appearance. Number two, what will these patients have? Recurrent infections. They will have recurrent infections, and they will have congenital heart disease. They will have hypocalcemia. And if you check their parathyroid levels, they will be primarily low parathyroid hormone levels. Okay. And you can get a specific T cell counts done. So T cell counts are known as CD4 CD8 ratio. They will be down. Okay. So this will be disturbed. So you will come to know that the patient has deficiency of the T cells. Otherwise, if you want to do a genetic diagnosis, what will you do? You will send a genetic sample. From where will you take the genetic sample? Any idea? Where do you take the genetic sample usually?
Bronchial mucosa.
Buccal mucosa.
Buccal mucosa, sir.
It is the buccal mucosa. Just like in COVID times, they were taking throat swabs. All you need to do is take a buccal swab. So you check them for what is the diagnosis test? It is FISH. What is FISH? FISH is fluorescence in situ hybridization. What will it tell you? What does the patient have? So it will tell you that there is a problem with the 22nd chromosome long arm. You want to go further inwards, you perform a test that we learned in the last lesson, microarray assay, microarray analysis. So what does it show? It shows that there is a deletion of 22q11 second segment. And of course, serum calcium levels and serum parathyroid levels have to be done. So in DiGeorge, you will not administer any live viral vaccines. This you will never give them. Okay? Live viral vaccines are not to be given. Big no. Okay? Anything else?
No, sir. Very well said, sir.
So,
Thank you.
So this is what is important from MCQ point of view, that one is the syndrome you need to identify from the facial feature, from CD4, CD8 cell counts, from hypocalcemia, congenital heart defect, echocardiogram, and along with that, you do not give them any live viral vaccines. This is important. So that is DiGeorge disease caused by microdeletion on 22nd long arm 11.2. Is that okay? And how do you investigate? Fish plus micro array assay. How do you treat? Give them vitamin D supplementation, give them calcium. Aajkal to we have a recombinant parathyroid hormone also available in the market. So you can give that to them, but that will only help them, not have seizures and tetany. Otherwise, whatever mental deficiency that they have, it cannot be recovered. All right. Now coming to a very important topic, which is a bridge between pharmacy and genetics, that is pharmacogenetics. So some people are fast acetylators, some people are slow acetylators, some people have a fast metabolism of certain drugs, some people have slow metabolism of certain drugs, some people have G6PD deficiency right from the birth, and you cannot give them primaquine. So these are the problems that you need to know and understand when applying genetics to your patients in the hospital or in the outpatient department. So what is pharmacogenetics? It is the knowledge of how genetic variations influence drug metabolism and the response to them. For example, there are so many polymorphic forms of CY cytochrome P450. It is one of the most famous enzyme, cytochrome P450. It has polymorphism. So it is an excellent example for pharmacogenetics. Then coming G6PD deficiency and HLA-B5701 in a specific drug of HIV, that is Abacavir. It will lead to a hypersensitivity response. So we have actually identified. These are some examples, and usually MCQs will come from these only because they are more robust and more trained to the students. A 35-year-old man of Mediterranean descent is prescribed primaquine for malaria prophylaxis. The moment the patient was given primaquine, the patient develops hemolysis shortly after starting treatment. What is the most likely genetic cause? So what is the answer?
G6PD deficiency.
So G6PD deficiency. So they do not have this enzyme in their body. So how will you diagnose G6PD deficiency? Any idea? Any person who can give me a response on that? How do you work up a patient of G6PD deficiency? Somebody tells you, I think this patient has G6PD deficiency. What are you going to do? Any idea? So G6PD is an X-linked condition, predisposes to hemolysis when exposed to oxidative stressors like primaquine. So when I say hemolysis, okay, tell me what are the diagnostic tests for identifying hemolysis? Anyone? Your
Direct
aspirants?
test.
Say again?
Direct home test.
Paraquine?
Direct home test, DCT.
Okay, direct Coombs test, direct, indirect, both. But before that, will you have
LDS,
something?
LDS level.
Even before that,
Peripheral it means?
Yes, you get a peripheral blood smear to look for
Hemolysis, adjoint.
Schistocytes.
schistocytes. Number two, if the hemolysis is happening, what will be produced? Serum bilirubin. Which fraction will be increased?
Indirect.
Direct.
Serum bilirubin will be increased. LDH will be increased. LDH is a byproduct of breakdown of plasma membrane. So wherever cellular damage occurs, LDH increases. Anything else? Anything else?
Haptoglobulin.
So, if RBCs are broken down, how will bone marrow compensate for a rapid breakdown of RBCs?
Increase reticulocyte count.
So, we will do a reticulocyte count, which will be increased. Bilirubin indirect will be elevated. I was just thinking about it. Indirect. Direct is after glucuronidation. So, indirect hyperbilirubinemia will be there. Indirect. Sorry for. So, okay, red count will be increased, and when the hemolysis happens, a protein is consumed. Which protein? Which binds to free hemoglobin. Haptoglobin levels. What will happen to haptoglobin levels?
Reduce.
Yes, they will be reduced. So these are the generic tests for hemolysis. So number one, PBF. Number two, serum indirect bilirubin. Number three, reticulocyte count. Number four, increased LDH levels. Number five, decreased haptoglobin levels. And we can do a Coombs test also. Negative. This will be negative. Why negative? Because Coombs test is positive in
Autoimmune.
Okay. So, anything specific for G6PD hemolysis? They are known as Haynes bodies. Okay. And anything else that you can do with is G6PD enzyme level or enzyme assay you can do. All right. Is that clear? Is there any benefit of having G6PD disorder?
Plasma idiopathic therapy.
Yeah. So the pearl, MRCP pearl, is that these people are inherently resistant to Plasmodium falciparum. Is that okay? So G6PD is an X-linked condition, and we need to remember about this. It is a very important condition. Usually hematology forgets about it. It is only the genetics which remembers about it. All right.